Now we will concentrate on the later toxicities of antiretroviral drugs. Again, these are my disclosures. My institution has been reimbursed for my time on advisory boards for Gilead, ViiV, and Merck Sharp and Dohme. So in this module, we're going to describe the longer-term events related and unrelated to antiretroviral therapy involving the kidney, involving bone, the cardiovascular system, metabolic disease, liver disease, neuropsychiatric disease, and cancer risk. We're also going to mention stopping antiretroviral therapy and switching therapy due to toxicity. This slide is a great example of the importance of using a good control group for looking at comorbidities in individuals who do not have HIV and people living with HIV. This data comes from the Netherlands, the age 4 cohort, and they took people who were men who have sex with men who were negative and people living with HIV and looked at comorbidities by age. So you can see on the left the HIV negative group with ages 45 up to 65 plus, and compared comorbidities which were 0, 1, 2 or 3 or more. And you can see that in the HIV negative group at 65 and over, some 45% had 2 or more comorbidities compared to 70% in those living with HIV. Now, why is that? Why do people with HIV have more comorbidities? And it's because there's an interplay between chronic immune activation, chronic inflammation, which drives many of our comorbidities, as well as toxicity from antiretroviral therapy, effects of HIV itself, and an overrepresentation of traditional risk factors for many of the comorbidities. So we're going to start with kidney disease. And this is a reminder, we talked about this in the acute toxicity module, that there are pathological and physiological causes of change in kidney function. The pathological causes are acute tubular necrosis, tubular dysfunction, and chronic kidney disease, whereas the physiological changes, which are a change in the measurement but not of the true kidney function due to our medication being used, predominantly rilpivirine, cobicistat, dolutegravir, bictegravir. And there is an increase in creatinine of about 10 micromolar and a decrease in the eGFR of about 10 to 15 mils per minute that occurs on initiation of the drugs. It occurs within days of starting them. And so there is a new set point for the eGFR and creatinine while those medications are being used. This is also a reminder from the previous module about kidney function, and kidney disease is considered at an eGFR of less than 60 mils per minute. And a reminder that antiretroviral dosing may need to be modified according to the eGFR or not used. Now, this data comes from the Eurocida cohort and shows that people living with HIV, of which there are about 7,000 to start with, over time progressed to chronic kidney disease, which was defined as an eGFR less than 60 or a 25% reduction in the glomerular filtration rate. The important thing to look at in this graph is that over 2 years, 48 months, it's really 4.5% that progress, with 3.3% of all people living with HIV progressing to kidney disease over a median follow-up of 3.7 years. So we're not talking about enormous numbers of people. The long-term renal issues that we need to consider are really those of traditional kidney disease affecting the general population. We need to also look at antiretrovirals, the use of tenofovir, disoproxil fumarate, and atazanavir. So we regularly assess kidney function every 3 to 6 months, depending upon how frequently the individual is coming to be assessed in clinic. For the first year, it should be more regular. There should be an annual urinalysis performed and a urine protein creatinine ratio done. If there is a new onset of renal impairment, what do we need to think about? And one of the most important things is one of the antiretroviral drugs causing a physiological decrease in the EGFR? Has that been started recently? Because we are switching and changing our antiretrovirals all of the time. So that is one of the most important things to think of first. And then also look at the trend in the change in EGFR. If it is a physiological change, it will be an acute change that then remains stable thereafter. But if the trend is a continuing change, then we need to consider other causes of renal impairment. For example, diabetes, hypertension, which is very common in people living with HIV, as is hepatitis co-infection, and the use of nephrotoxic drugs. We also need to exclude obstruction, pre-renal, renal, and post-renal causes of renal impairment. The obstruction can be assessed doing a renal ultrasound, and that ultrasound could also look for renal artery stenosis. We can evaluate proteinuria by doing a urine albumin creatinine ratio and a urine protein creatinine ratio. If it is only the urine albumin creatinine ratio that is elevated, it is likely that it's a glomerular cause of proteinuria, which means a glomerulonephritis. Patients on tenofovir, disoproxil fumarate are often quite tricky to assess because of the high rates of background kidney disease, and whether it is tenofovir causing the kidney disease or other causes is very difficult to disentangle. It is very important to exclude Fanconi syndrome because tenofovir should be ceased immediately if that is present. You do that by checking a serum phosphate and urine for glucose and protein, and if there is proteinuria, the urine protein creatinine ratio, urine albumin creatinine ratio to distinguish the tubular from the glomerular proteinuria, and always discuss with your mentor and renal physician. The management of renal impairment I never do on my own. I do it with my renal colleagues. The proteinuria and hypertension is usually managed with ACE inhibitors or angiotensin II receptor blockers. I do ensure appropriate renal dosing of the antiretrovirals, and I do that in conjunction with my friendly HIV specialist pharmacist. And I also, with her, look at potentially nephrotoxic medications that we could cease and consult with a renal physician. If there's a falling glomerular filtration rate with or without proteinuria, or Fanconi syndrome without other causes of kidney disease, and the patient is on tenofovir disoproxil fumarate, switching off it is highly recommended. If you don't switch before the glomerular filtration rate falls below 70, some studies have suggested that the change in renal function is irreversible. These studies were done earlier, and I think it's difficult to exclude other causes of kidney disease causing the renal impairment. I think today we have other antiretroviral drugs, and so if you're on tenofovir disoproxil fumarate and you have abnormal kidney function, I would switch from the TDF to either TAF or other antiretroviral regimens. If the individual also has chronic hepatitis B, then switching to TAF is recommended if there is not severe renal impairment. And always consult the renal physicians. Now, HIV and bone disease is becoming more of a problem as our population, people living with HIV, age. We have known for many years that people living with HIV have higher rates of fractures than their aged matched negative population. This is women at over the age of 50, where those living with HIV have marked increase with double the rates of fracture. And you can see for men, the lines separate at the age of 40 with greater rates of fracture. Osteopenia and osteoporosis are very common in HIV. It's associated with antiretroviral therapy, and the greatest loss of bone mineral density occurs with regimens that contain tenofovir disoproxil fumarate. We are currently unable to predict which patients are likely to lose more bone mineral density or develop osteoporosis on antiretroviral therapy, but data support cessation of tenofovir for reversal of low bone mineral density. Osteomalacia is uncommon and associated with vitamin D deficiency in our patients. And osteonecrosis also occurs, and the risk factors for this is low CD4 cell counts, the use of steroids, and injection drug use. So the risk factors for low bone mineral density in HIV are multiple, and they can be divided into the traditional risk factors here, HIV infection-related, antiretroviral treatment-related, and secondary causes. So it is always important to rule out secondary causes of osteoporosis in people living with HIV with low bone mineral density. So we should be screening people. Who do we screen? We screen anyone over the age of 40. And how do we screen? We screen with the FRAX score. We screen measuring vitamin D, calcium and phosphate, and exclude testosterone deficiency in men. We screen 3 yearly, and then we screen annually over the age of 60 with the FRAX. Who gets a DEXA scan? I think postmenopausal women should be scanned. Men over the age of 50, it's recommended in all guidelines to get a DEXA scan in men living with HIV, but unfortunately is only reimbursed over the age of 70 on the MBS, unless you establish osteopenia. Anyone who's had a fragility fracture, who has hypogonadism or has used 3 months of steroids should also get a DEXA scan. With the FRAX, we recommend all individuals over the age of 40 to have a FRAX assessment. Anybody with a history of fragility fracture, those taking glucocorticoids, prior to antiretroviral initiation, and anyone with a high risk of falls, which is usually our older patients. And FRAX can be used with or without bone mineral density. This is the FRAX fracture risk assessment tool. If you haven't seen it, it's an online tool. We should be using the Australian version unless you have someone who has recently migrated from other countries. It's interesting, you can alter the country of origin and you will get different fracture risks. For example, the Scandinavians with exactly the same age, sex, height, weight, etc., will have higher fracture risk than the Australians. Anyone who has a FRAX score less than 40, anyone who is aged less than 40, you can do a FRAX, but the FRAX algorithm assumes they are 40. It hasn't been validated in the HIV population, and experts believe that you should consider HIV as a secondary cause of osteoporosis in that calculation. Younger patients with higher fracture probability should go on to have a DEXA, as should those with fracture probabilities greater than 10% or greater than 3% for hip fractures. All antiretroviral regimens cause loss of bone mineral density when you start them. It doesn't matter which regimen it is, you lose bone. But we do know that protease inhibitor containing regimens and tenofovir disoproxil fumarate are associated with greater bone loss. How do we manage patients? We ensure that they have adequate dietary intake of calcium. We ensure their vitamin D replete. We encourage smoking cessation, modification of alcohol use, increased weight-bearing exercise, and falls prevention. Always exclude the secondary causes of low bone mass and treat them. And we change our antiretroviral medications associated with bone loss, but only if it's safe to do so. And treatment for osteoporosis is recommended. We'll move on now to metabolic and cardiovascular disease. Now these appearances, this is lipodystrophy, this was described in the late 90s, was due to the use of earlier, more toxic antiretroviral therapy. NRTIs, particularly the thymidine analogues, were associated with loss of peripheral subcutaneous fat and facial lipoatrophy, and the protease inhibitors were associated with accumulation of central fat, visceral fat, and also were associated with hyperlipidemia and diabetes mellitus. This doesn't occur with the current antiretrovirals, but you will still see individuals treated in the 90s who have persistent changes of lipodystrophy. Hyperlipidemia is caused by the protease inhibitors and to a lesser extent cobicistat. The efavirenz will cause an increase in triglycerides predominantly, and rilpivirine can cause some minor increases in your lipids. Cardiovascular risk is significantly increased with abacavir, also with the older protease inhibitors and darunavir, but atazanavir is not associated with increased cardiovascular risk, and neither are the integrase inhibitors associated with increased lipids or cardiovascular risk. This is data from the Data on Adverse Events study showing with longer use of antiretrovirals an increasing incidence of acute myocardial infarction. Now, the pathogenesis is very complex. It may be due to HIV itself. It's also due to the chronic inflammation associated with HIV infection, but we also know that abacavir doubles your risk of cardiovascular disease and the use of the protease inhibitors. But we mustn't forget the traditional risk factors. Age drives most cardiovascular disease, as does a strong family history. Smoking is incredibly important. Our population of people living with HIV still smoke at higher rates than the general population. Diabetes mellitus and hyperlipidemia, hypertension and chronic kidney disease all increase cardiovascular risk. This is the data from the DAD study showing in the darker blue the no recent abacavir, and in the lighter blue recent abacavir. Overall, you can see a doubling of risk of acute myocardial infarction, but it is those with the highest risk of coronary artery disease that have the highest rate with abacavir. So very important, those with high cardiovascular risk should not receive abacavir. This is reassuring data that you can tell your patients that if you, this is data again from the DAD study looking at rates of myocardial infarction for those who've never smoked, those that have previously smoked, and those who currently smoke. And then the rates of myocardial infarction by time after cessation of smoking. And you can see that there is a decrease in risk of myocardial infarction that continues to decline for 3 years after cessation of smoking. So it is worth stopping. How do we manage acute myocardial infarction with antiretroviral therapy? We always review the antiretroviral therapy. So if someone is on abacavir who has actually had a myocardial infarction or has ischemic heart disease, cease the abacavir, change antiretroviral therapy. If they're on a boosted protease inhibitor, where it is possible, we should be consider ceasing that as well and changing to an integrase inhibitor. We always review all medication when someone has had ischemic heart disease or cerebrovascular disease, because many of the treatments interact with the antiretroviral medications. So there may be significant drug interactions unbeknownst to the cardiologists. We need to ensure that people living with HIV continue appropriate secondary prevention and continue to work with people who continue to smoke to reverse risk factors, so to cease smoking. So how do we screen? We measure blood pressure regularly. We do fasting lipids and glucose, and we assess the Framingham risk using CVD check. We do it at diagnosis. We do it annually after initiation of antiretroviral therapy. I measure lipids annually in people who have reasonably normal lipids, particularly in those who are older. The lifestyle management is management of hyperlipidemia and encouragement to quit smoking. Statins are appropriate for those with high cardiovascular risk. We've done a recent study looking at the use of rosuvastatin in those with intermediate risk, given the double the risk of cardiovascular disease in people living with HIV, but there was no reduction in surrogate markers of liver disease with the use of rosuvastatin. So only use the statin in those that you would normally use a statin in the general population at this point, and ensure that blood pressure is controlled with antihypertensives. Switching antiretroviral therapy should be done with your mentor, but in particular, consider a switch in those with high risk on abacavir and protease inhibitors. So in men greater than 40 years and women greater than 50 years, do the CVD check. Liver disease. Our patients with HIV have much higher rates of liver disease compared to the general population. And in years gone by, this has been due to higher rates of hepatitis co-infection. Hepatitis C occurred in about 15% of our patients living with HIV. But now this is changing with the ability to cure hepatitis C so readily with non-toxic, easy-to-use medication. We know that people with hepatitis B and hepatitis C co-infection that is not treated have faster progression to cirrhosis. So it is very important to exclude those, and they should be screened for both reactivation of hepatitis B or hepatitis C reinfection if they've already had HCV cured, in those that are at risk of acquiring hepatitis C on an annual basis. More important liver disease in 2020 is non-viral liver disease, and NASH or steatohepatitis and non-alcoholic fatty liver disease predominate in our patients because of the higher rates of metabolic syndrome and diabetes in our patients. For patients who have co-infection with hepatitis B, it's very important that we assess for cirrhosis, and if they are cirrhotic, they should be referred for regular screening for hepatocellular carcinoma. We monitor, we do screening for hepatocellular carcinoma depending on age, race, family history, and stage of disease. The preferred regimens for people with hepatitis B and HIV co-infection include TAF or tenofovir disulproxyl fumarate, and FTC, which is emtricitabine, or its cousin 3TC, lamivudine. So dual therapy for HIV and hepatitis B. You should use 3TC alone or FTC alone with caution due to the development of resistance to hepatitis B using monotherapy. Abacavir and 3TC or Kyvexa is basically monotherapy for hepatitis B, so should not be used. And if you are considering the use of dolutegravir 3TC, you should ensure that the individual is not hepatitis B co-infected. If individuals are unable to tolerate tenofovir because of kidney disease or Fanconi's or significant bone disease, one should use entecavir, and you can monitor for hepatitis B and disease progression and hepatocellular carcinoma screening as indicated. Always seek advice from a hepatologist. What about co-infection with hepatitis C? Well, treat. Treat the hepatitis C with direct and acting antiretrovirals. They are as effective in people living with HIV as in the general population. They have very low toxicity with greater than 95% cure rates. Treatment is usually for just 8 to 12 weeks. There are drug-drug interactions with TAF and the protease inhibitors, so it is important to check the drug interaction website when choosing your DAAs for hepatitis C treatment. Monitor for sustained virological response 12 weeks after completion of therapy. There are guidelines at hepcguidelines.org.au, and we recommend that you seek advice if you're not accustomed to treating the hepatitis C. Neurological presentations are also not uncommon in people on effective antiretroviral therapy, and they can be HIV-related, such as HIV-associated neurocognitive disease, or due to CNS opportunistic infections, including progressive multifocal leukoencephalopathy. Or they can be non-HIV related, such as Parkinson's disease, which appears to occur a little more commonly in our patients living with HIV, but also due to cerebrovascular disease with strokes, and this often requires specialist assessment. So with HIV neurocognitive disease, there is a spectrum ranging from overt dementia, which is very uncommon, to symptomatic disease or asymptomatic neurocognitive impairment. And you may not be aware of the neurocognitive impairment on routine reviews unless you start asking the individual about work, social, managing money, etc. The associations with hand lower CD4 cell count need DIAs, having had a cerebral opportunistic infection, either an infection or lymphoma, hepatitis co-infection, pre-existing cardiovascular disease, hyperlipidemia, and hypertension. There are confounders, people who use recreational drugs, who consume greater amounts of alcohol than recommended, or who have concurrent psychiatric diagnoses. The assessment for neurocognitive disease is problematic. The detailed assessment for hand includes a lumbar puncture to measure a CSF HIV viral load, but also to exclude other opportunistic infections and lymphoma. An MRI of the brain to exclude T2 hyperintensities characteristic of hand, but also of cardiovascular disease and dementia from other causes, and neuropsychological assessment by a neuropsychologist. The management approaches vary and may include change in antiretroviral therapy to include antiretrovirals that have higher concentrations in the central nervous system. But management of hand should always be with a specialist in the area. What about cancers? Cancers are becoming more common in our patients who are living with HIV. The AIDS-related cancers, Kaposi's sarcoma, non-Hodgkin's lymphoma, and cervical cancer are reducing because of effective antiretroviral therapy and are really most often seen in those that are unaware of their HIV diagnosis and have progressed to significant immunodeficiency. The non-AIDS cancers appear to be increasing and may be related to traditional risk factors such as smoking, but also alcohol use and immunodeficiency. As a reflection of the rate of non-AIDS cancers by CD4 cell count, you can see that any infection-related cancer, there are higher rates in those with lower CD4 cell counts compared to those with the normal CD4 cell count greater than 500. This is the same for anal cancer, that's HPV-related, Hodgkin's lymphoma, which is EBV-related, oropharyngeal cancer, which is EBV-related. But there is also a significant increase in those that have infection-unrelated cancers such as melanoma, such as colorectal cancer, not melanoma. What are the implications for clinical practice? Cancers can occur at any CD4 cell level. And it's important not to think just because someone has a normal CD4 cell count, they can't develop a cancer. Smoking is clearly very important with the development of many of these cancers. So those people with HIV who continue to have high rates of smoking often have higher rates of cancers. So never ignore symptoms and signs in a patient with controlled viral load and good CD4 cell count. So how do we screen? The cervical screening test should be done 3 yearly in women, and there should be more frequent review at the time of HIV diagnosis. Anal cancer screening, it's recommended that individuals over the age of 50 have annual digital anorectal examinations or evaluation of symptoms, because if the cancer is picked up earlier, outcomes are better. And then we follow the general population recommendations for other cancers: lung cancer, bowel cancer, breast cancer, prostate cancer. Now, we never ever recommend cessation of antiretroviral therapy or interruption of antiretroviral therapy. We know that it is not smart to stop antiretroviral therapy, and this is from the SMART study that was done over 10, 15 years ago now. The SMART study randomised people who had controlled HIV with CD4 cell counts greater than 350 to either stop their antiretroviral therapy and to restart it when the CD4 cell count hit 200, or to continue antiretroviral therapy to maintain virological suppression. Now, this study was designed in the days when antiretroviral therapy was expensive and could not be rolled out because of finance to many areas in the resource-limited setting. And so the thought was, can we protect people from opportunistic disease and death by just using antiretroviral therapy during the times of CD4 cell risk? The answer was no. The study was stopped early because there was a much higher rate of opportunistic infection, death from any cause, and also serious non-AIDS events in those that stopped their antiretroviral therapy. And it was the SMART study that started the raft of research on serious non-AIDS events and inflammatory disease and chronic immune activation. You can see that this is the arm that stopped and started therapy. This is the arm that had continuous therapy. This is the percent of individuals that developed an AIDS event or died, and you can see that these arms separated from as early as 8 months after the start of the study, but was significant. And the Data Safety Monitoring Board stopped the study early and everybody went on to therapy. Switching antiretroviral therapy is the most common thing that you will do today, as the number of new diagnoses of HIV continue to decline. Why do we switch therapy? We switch therapy for a number of reasons, but it's important that we don't switch therapy in someone who's virologically suppressed and cause virological failure. We only switch a single drug when the viral load is suppressed. You never, ever, ever switch one drug when someone has virological failure, but that will be assessed in a later module. And it's always important to ask yourself, will the new antiretroviral drug or the new antiretroviral regimen maintain virological suppression. And we do that by looking at the potencies of the drugs, pre-existing resistance by reviewing past genotypes and reviewing the entire antiretroviral history and why and when prior regimens were switched. We also ask ourselves, will there be new toxicities or drug interactions with the new regimen, so that if you're switching, for example, from TDF to TAF and the individual has tuberculosis, you can't switch because of the interaction between TAF and rifampicin. So always look at the Liverpool HIV drug interaction website and look for potential new drug-drug interactions with the switch in treatment. So why would you switch and when would you switch? So the most common reason probably today is for simplification, to move to a single pill, or toxicity. And that toxicity can be renal, as we looked at today, metabolic, due to liver function abnormalities or neuropsychiatric abnormalities. It may be because of pregnancy. It may be planned pregnancy or pregnancy, because there are a number of drugs that have not shown to be safe in pregnancy, and we want to ensure happy outcomes for both mother and baby. We also may need to prevent HIV drug interactions or toxicity with a new comorbidity, and some of those are listed there, with cardiac morbidity and use of cardiac medications, the new direct DOACs, asthma, hepatitis C, and increasingly common is transplantation and the use of immunosuppressant drugs in transplantation. So if you have any questions about toxicities, early and late, comorbidities, the use of antiretrovirals, and switching,